Today, I'm really thrilled to have Michael Sinha. Mike, who I've known for a number of years and have worked closely with on a bunch of projects, including COVID, is a research fellow at the Harvard MIT Center for Regulatory Science at Harvard Medical School. He is also a visiting scholar at the Center for Health Policy and Law and has been an adjunct member of the Northeastern University School of Law faculty. We're really thrilled to have him with us today to talk about worker safety and PPE. Again, this is an informal conversation, so I think we'll have plenty of time for discussion after Michael's presentation. So, Michael, thank you so much for joining us.
Thank you. Let me load my slide. So this is a conversation about healthcare worker safety and PPE. This is based largely on work that I've been doing for the last 6 months at Harvard Medical School. So in March of 2020, which was about the start of the peak of COVID-19 in several cities, including New York City, there was a cry that we needed PPE. The World Health Organization noted that the chronic global shortage of PPE is one of the most urgent threats to our collective ability to save lives. New York Times noting that nurses were dying and doctors were falling sick. Panic was rising along the virus front lines. And Stat News reporting that healthcare workers were scouring for masks on their own because they were not getting them from their institutions. This was borne out via a campaign on social media. So Dr. Esther Chu, who is an emergency physician in Oregon, put out a call and asked any healthcare employees that said they did not have PPE to post with the hashtag #GetMePPE. This eventually morphed into a nonprofit organization called GetUsPPE.org. This is a sort of a hub where people can donate PPE and it gets redistributed to hospitals and other centers that need it. Now, fast forward to September 2020, the hashtag really should be "We Still Need PPE." So Dr. Megan Ronnie, who's also part of Get Us PPE, notes that supply does not meet demand and really points to a lack of government support in this regard. I think we're all sort of on the same page in recognizing that. Dr. Esther Chu highlights that we still need PPE nationally and points out that Get Us PPE can only supply 10% of the requests that are being reported to them. And Dr. Jonathan Reiner points out that physicians and other healthcare providers are reusing N95 masks 9 months later. So I noted in a presentation to a group of public health lawyers last week, several consensus reports foreshadowed our need for PPE during a pandemic. And I really want to walk through these because they essentially lay out this very clearly, that the need for PPE, the need for reusable PPE, was a problem that was being anticipated. And it was long before this administration came on. So in 2006, a report looking at influenza pandemics noted that disposable medical masks and respirators were not designed for reuse. And there is nearly universal agreement that reuse, even by a single user, should be discouraged except in the most extreme and dire circumstances. In 2008, a report focusing on PPE for healthcare workers noted that the varied regulatory certification and evaluation requirements for healthcare PPE have largely evolved in a fragmented manner. There has not been a coordinated effort to analyze the entire life cycle of healthcare PPE or the wide spectrum of the user population. By 2019, we start looking into alternatives to N95 masks, these elastomeric respirators. The committee concludes that urgent action is needed to resolve gaps in knowledge and leadership on reusable respiratory protection in order to protect the health and safety of healthcare workers, particularly in an influenza pandemic or an epidemic of an airborne transmissible disease. Little did they know that within 1 year we would have exactly that scenario unfold. And so the legal authority for emergency use authorizations during COVID-19 requires a declaration of a public health emergency related to COVID-19, which occurred on February 4th, pursuant to Section 319 of the Public Health Service Act. This also included a separate declaration required to give the FDA discretion to use emergency use authorizations, noting that circumstances existed justifying the authorization of emergency use of medical devices. And this included alternative products used as medical devices. And under Section 364 of the Federal Food, Drug, and Cosmetic Act, the FDA commissioner may allow unapproved medical products or unapproved uses of approved medical products during the emergency, so long as there is no adequate, approved, or available alternative. And you'll note the chemical, biological, radiological, nuclear defense, CBRN threats. So thinking about this in the context of bioterrorism. This was a short piece I published with colleagues at Harvard Medical School. We noted that nationwide shortages in PPE have resulted from fragile international supply, just-in-time manufacturing, lean inventories, and limited incentives to innovate. And that during the COVID-19 pandemic, local fabricators, makers, and 3D printing communities have stepped up to produce PPE for the front line. We also found that EUAs were only really needed for certain high-risk categories of PPE, such as methods of sterilization or manufacture of filtering face piece respirators like N95s, and not for some of the lower-risk categories like face shields and gowns, of which there are also significant shortages. So this is the organization I've been working for the past going on 7 months, known as PanFab, the Greater Boston Pandemic Fabrication Team. We aligned closely with the incident command leaders at Brigham and Women's Hospital. Our goal at that time was to try to address needs at the hospital level. We found needs for a variety of different things, so test swabs for COVID-19 diagnostic testing. They even needed sanitizing wipes, so we were looking into alternatives for some of the commercially available products that were in shortage. Developed some face shields for emergency department physicians and employees. So these were some of the products we did develop. The face shields, as I noted, were tested, and we received clinical feedback from the physicians to make sure that they were optimized for clinical use. Mask frames, the idea here is you have an N95 mask, maybe it's been sterilized several times, maybe the elastic straps just broke before the first use. And this is a frame that improves the seal around the face and also has brand new straps to replace the ones that may have broken. The PAPR is the powered air purifying respirator. So this is a machine with a hood, essentially, and it filters the air through those blue and red filters. Those are just the covers for the filters. But then you wear that over your head, and it essentially provides 100% filtered air. And so the idea there is that you would use that instead of N95 masks to help conserve N95s. And then sterilization methods, as I noted, our research group studied, tested, and validated a sterilization method using ionized hydrogen peroxide. And we found that N95 masks could preserve fit and function after 10 cycles of sterilization, which shows that some of these masks that were really originally designed to be one and done can actually be safely sterilized and reused. And so I wrote a chapter for the Pandemic Policy Playbook, assessing legal responses to COVID-19. I focused in on state and local responses to PPE shortages. And the big question, the big take home from our chapters and the collection as a whole is, what do we do moving forward to improve the current response and to provide guidance for future responses? And so from this, I'd really like to go back to those original reports because they offer some excellent recommendations that we have really not been following. So the first, in 2006, the recommendation to sponsor and/or conduct research on the use of alternative materials, including bioactive fibers, for disposable N95 respirators to allow for extended use and higher durability elastomers for the straps. As I noted, the straps break often. A 2008 report noted that federal agencies, including the FDA, NIOSH, and OSHA, should use standards developed through a consensus-based, transparent process that sets specific and clearly defined limits regarding conflicts of interest. Now, I think this is especially important because in the sterilization context, there was a company that received a $400 million grant for its sterilization method to sterilize N95 masks. I think it was largely a political favor for a senator in Ohio to grant this Columbus-based company the grant. But the testing that they underwent for their process was far less rigorous than ours. Yet the company that sponsored the product that we were testing has still not received emergency use authorization after trying for the past 5 months. And so I think there's something political that's involved in this process as well. Congress should expand resources provided to NIOSH to further research efforts on the next generation of PPE and to coordinate and expedite the approval of effective PPE. In 2011, there was another report known as the Project Breathe Working Group, and at the time they favored the development of a new respirator class called the B95 or the biological N95 because the original N95 masks were never designed with bio products as an issue. So they were not focused on viruses and bacteria. They were focused on other airborne particulate matter. And that's part of the reason why you see one-way N95 mask with valves. The idea is that if it's fine particulate matter during construction, for instance, that what is exhaled is really not problematic because it's not infectious. The report also noted that designs should be utilized that prevent respirator-dependent transmission of infectious pathogens, and that a test should be developed, validated, and standardized that assesses respirator-dependent pathogen transmission in a clinical environment. So this is about a decade ago, and they're saying we should develop a test to study whether pathogens are transmitted in clinical environments, such as hospitals, using these various respirators. And this is something that could have easily been done much earlier. Some other recommendations, the FDA should revisit UAs and remove authorization from those that fail to conduct follow-up studies of safety and efficacy. The reason here is that the company I mentioned before hasn't conducted additional studies on the safety and efficacy of its sterilization process. They are only just one example. The CDC should finalize its Appendix A. I haven't talked about this in much detail, but Appendix A is the list that the CDC generated because there was an influx of counterfeit respirators entering the market primarily from China. The Appendix A was meant to be a list of validated respirators, and that list was edited something like 15 times over the period of 2 months. So that offered very little certainty as to whether, if I'm holding a KN95 mask from China, for instance, can I check that list to be certain that it's going to be safe for use? NIOSH, which is an organization under the CDC, hasn't updated any guidance related to innovation of N95s and PAPRs, and it should certainly do so if possible, although the CDC is under siege for a number of other reasons. The Secretary of HHS ideally could issue an OSHA emergency temporary standard. So OSHA, being the Occupational Safety and Health Administration, has the power to issue standards that employers must meet to protect health and safety of workers. Some states have the ability to do this, and some states like California, in fact, have issued their own standards. But it would be important for the federal government to step in and issue a standard for frontline workers who are exposed to COVID-19. And unlike the previous report, which suggested that NIOSH would be the agency tasked with research, we already have BARDA and DARPA, which were post 9/11 organizations heavily funded under the Department of Defense. And they have already been tasked with research into national security and biodefense. And so the issue there is perhaps they are researching and developing more sustainable forms of PPE, perhaps better methods of manufacture and dissemination of PPE. But a lot of the work they do is guarded as a state secret. And so the concern there is that that information is not being made public and disseminated broadly such that we can all in various states and localities take up that information. The last thing I will note is that there was a complementary chapter to mine in the pandemic policy playbook that was written by Scott Burris and Evan Anderson in Philadelphia. And they essentially focused on the Defense Production Act and federal solutions to PPE. Their focus was largely on the fact that DPA has been misused. For example, DPA might have, I think, would have been the authority to grant the contract for sterilization. But the authority is, as I said, been misused and has not been applied broadly enough across the varying types of PPE. So with that, I will open up to questions, thoughts, insights. I think the biggest issues here are employment and administrative law related. I'm not an expert in either of those two, so I welcome insights and thoughts about that as well.
Folks can feel free to put any questions or even comments that they have in the chat box. I'm also more than happy to have you share if you're interested in having a comment or speaking your question out loud. You can simply put RTS in the chat box and we call on folks for you to speak up. Wendy, do you want to read it out loud? It looks like there's one in the chat box. Do you want me to do it?
I'm happy
And of course,
I think it's
Emily, you're more than welcome
more
to.
of a statement that Emily made. I don't know, Emily, if you want to read what you wrote, or I can read it.
Great. So just it's a clarification that it's OSHA has not issued an NETS. OSHA's in the Department of Labor, not HHS, but about half the states have responsibility for OSHA enforcement. And so there are a number of states now that have either had pre-existing infectious disease standards, particularly California, and a couple, at least, Virginia has now promulgated one, and I know a couple of other states are working on them. So there is actually motion, even though not at the federal level at this point, for the, in terms of the availability of protection through health and safety enforcement.
Yeah, I guess my understanding was that during the public health emergency, the authority shifted to HHS to issue the emergency temporary standard.
No, HHS doesn't have the authority to issue the ETS over health and safety issues. OSHA clearly has that authority. There's a JAMA commentary online right now that was written by David Michaels, the guy who was the head of OSHA during the Obama administration, and Greg Wagner about the failure of OSHA to issue the ETS.
That's really good to know. So sub-states have actually issued guidances related to COVID-19, that's correct?
Well, there's a difference between guidance and enforceable standards. So Virginia's issued a really pretty good infectious disease emergency standard. I mean, Massachusetts has an workplace emergency regulation that in part bypasses OSHA because OSHA is completely missing in action on this. But it doesn't really address the issues that you're addressing and concerned about.
I noticed that Clark had his hand up. Clark, are you there? Do you have a question? We can come back around. It looks like Maria also has a question. She'd love to hear more from you, Michael, about any interactions and engagement that you may have had with healthcare workers, and particularly hearing from them what type of needs they have, what equipment might look like. She points out that N95 masks, as you point out, tend to break too easy. So, you know, what are you kind of hearing from the front lines? What are some of the observations?
Sure. So working with the PanFab group, we actually had access to frontlines clinicians. We also had other clinicians who are involved in the group that provided feedback. So I can give you an example of the face shield. There is a template of a 3D printed face shield that most people in the US started with when it came to 3D printing them. Couple of things the clinicians noted. The first was it didn't go far enough around the face to protect if they were turning back and forth from aerosol particles. So we had to make the shield a little bit wider. It also, the concern a lot of the healthcare providers offered was that in the process of intubating patients with COVID-19, that was one of the most potentially hazardous times in terms of aerosolization of viral particles. And so they actually designed and built a lid or a shield that went on the top of the face shield. I may be able to see it in the picture, but the idea there was that if you have the shield in place, those droplets would just run down and not in front of the user's face. So you can see up here, there's a little bit of a gray shield that protects the top of the head. So the nice thing was we did have direct access to the emergency department because the physician who is leading the incident command at Brigham and Women's Hospital was a founding member of our group. And so we got daily insights as to what they needed, what was going on, what products were being used, what was nearing shortage. All of that information was given to us in real time.
That's great. Brooke, I see that you have a question or comment.
Yeah, thanks, Michael. It's really interesting. So I have a couple questions, mainly on the policy front. So, I mean, you described two different kinds of problems, or, well, at least two. Certainly one is innovation, the lack of innovation and incentives for innovation and guidance for innovation. And then some secrecy with respect to whatever innovation is taking place. So, I think the exploration of other systems for incentivizing the needed research and development of new products and new approaches really is something worth, us all thinking about and exploring. But it's also, intimately connected with the issue of inadequate supply. And, we basically have an innovation ecology in this area and many others where we rely on intellectual property, patent protections and or trade secret protections principally as the incentive system. But, that doesn't necessarily guarantee scale up of supply. And, we have, very little either push or pull mechanism that encourages companies that do come up with innovations to actually license increased manufacture to share the technology so that we can really rapidly scale up supply. We kind of leave it totally to the right holder to figure out whether they can expand their own internal manufacturing capacity or whether they can partner with a self-selected commercial partner. But even though, as you said, we have this federal authority to manufacture the Defense Act, we don't really use that. But more particularly, we don't. Even if we were to support and incentivize innovation, we don't put any conditions in terms of open licensing and technology transfer. So I just wonder to what extent, the folks that you work with, even in the PPE area, are thinking about the innovation, supply, access, ecology, and kind of, different approaches or policy alternatives to address those issues.
Yeah, absolutely. So one of the things we thought about, especially when we were writing up our 3D printing editorial, was the idea that there's really not much of a profit margin to be gained on some of these products. So these are, for example, flimsy face shields that are inserted into surgical packages or, available in an emergency setting. Maybe you make 5 or 10 cents per item. So there's not a financial incentive to innovate in that space. We've also seen funding for a number of agencies, including the NIH, decrease substantially over the years. Political threats to continue to cut back on funding for various research objectives that Congress has thus far held off. But the idea being, if this is something that's not facing us as a challenge right now, I think Congress has been very reluctant to put funding for it. And even when there are challenges that do immediately face us, the tendency there is to severely underfund those issues. So offering, $1 billion in funding for the opioid epidemic, when we know that we need probably 30 times that to adequately respond in a timely fashion. I think that's just an example of the federal government not being willing to step up and overfund now to be better prepared in the future.
Brooke, did you have any follow-up?
Yeah, I did wonder about the supply side of it too, because the one issue is, there's also, there should be incentives to massively increase supply beyond what a company may have its own internal commercial chops to accomplish, right? I mean, there ought to be just, if something good is available, then, let's mass produce it. And mass produce it not just for healthcare. I mean, I think partly what we've seen is, and part of the vulnerability that's experienced by people trying to, essential workers trying to move around, is they don't have good alternatives at this point. They don't have something comparable to protect themselves as they go into higher risk areas. Or we don't have, we don't send out face masks to people who need to go to medical appointments. I mean, there's so many more uses that we have for these products that, we need a huge supply. We need funding to, of course, supply it. But, we have a very narrow conception of use cases at this point.
Yeah, I think that's absolutely true. The one thing that Scott Burris and Evan Anderson noted in their chapter was we really need to rethink how we fund the strategic national stockpile. And so it needs to expand much more significantly. My thought when I was having a conversation with them is why not have state-based stockpiles in certain settings, especially if in urban places like Boston, where we have a number of hospitals, you have a surge supply that can accommodate additional PPE needs above and beyond what the Strategic National Stockpile can provide. And then we're also thinking about how 3D printed PPE could be produced and stockpiled as well for future pandemics.
Wendy, you had a question or a comment?
I have two questions, and I think actually they both follow from your last discussion with Brooke. The first goes to, what can be done to incentivize, how much of this has to do with, you've been talking about stockpiles and et cetera, but to what extent is part of the problem the lack of incentives within the healthcare system to have, a redundancy, right? To, so that until the pandemic comes, you have this just-in-time supply chain, and there are incentives for that. And if you didn't have those incentives and you had a different sort of system of warehousing within hospitals, could you get there through healthcare financing, and would that then change the production, right, through the supply side? So I guess I want you to follow up. Let me just throw out my other question, which is somewhat different, but also touches on earlier conversation, is whether you could talk at all about the issue of PPE in nursing homes and for home health aides. Right? Because my sense is, to whatever extent the problem has been solved, and it hasn't for hospitals, the situation is probably a lot worse in these lesser resourced sectors. And particularly, I think about home health aides who are not sort of in a, if whom are actually, some of whom don't even necessarily, some work for employers officially, some don't, but often are going from patient to patient to patient, and obviously very vulnerable patients. So PPE is really important, and I'm not hearing a lot about PPE in those sectors.
Right. So I guess to your first question, I think in hospital settings, there's very little incentive to procure and have more supplies on hand, because generally what happens when you, for example, if a hospital submits for reimbursement for a hospitalization for pneumonia, they get a full package amount for that hospital stay. And so that amount covers literally everything needed for that hospitalization. And if it's, for example, a MRSA pneumonia for which physicians, anyone else who has to go into the room of the patient has to gown and glove each single time, that additional cost is borne into that lump payment, regardless of whether it's resistant or not. So I think hospitals think about it as, this is cutting into their bottom line already. And so maybe that's part of the reason that it's not, there's no or little incentive for them to stockpile it. And as to I'm trying to think of your second question. Can you jog my memory?
Yeah. I was asking about what's being done to ensure adequate PPE.
Right, nursing
homes and home health workers.
Yeah, I think that's a setting where OSHA standards would be the most meaningful, because hospitals are accredited by the Joint Commission, nursing homes and other skilled nursing facilities have accreditation standards, but I don't think they're held to the same degree of employment protection. And so I think part of that challenge is if we have a way to mandate that certain essential healthcare workers are protected, then you're going to see a change in attitude among those institutions. But I'm not sure that there's it comes back to money again and resources So they may not have enough resources to provide PPE to go room to room to room, but I think that's part of the challenge.
Do others have questions? I could keep talking, but I'd rather make sure everyone has the chance. Rebecca.
Thanks, Wendy.
Hey, hi.
Curious, Michael, if you, and you may not know this data, I don't know if it's actually out there or not, but if there's any data on the rate of transmission between patients and providers, and if that data has been reassessed so that we know how it has changed throughout the pandemic, and if that's affected by PPE or if it's more affected by our understanding of, you know, aerosolized transmission versus fomite transmission.
Which
Yeah, I
changed
think
again
that's
twice in 24 hours, right?
Yes, exactly.
right.
That's why I said this may not even be available, let alone in his head for information already.
You know, I think the biggest problem in the COVID-19 pandemic is trying to identify the source of transmission at any point. And so that includes perhaps it's healthcare transmission among employees, or perhaps that essential worker went out to a restaurant that evening and that's where they contracted COVID-19. So I don't think we have enough information. The lag time between exposure and infection being roughly 5 to 9 days, you know, that's a pretty broad window of time. So we don't really have the same kind of, I guess it's the same kind of disease that we would need to be able to more accurately pinpoint sources of infection. But what we do see, for instance,
Michael, you're muted suddenly.
all right. So at Brigham and Women's Hospital and Mass General Hospital, they implemented mandatory masking for everybody who came into the hospital, including visitors. And there was a decrease in the number of employees and visitors and other patients that were contracting COVID-19 in the hospital setting. But I think there are too many confounding factors to be able to say that mandatory masking among all persons in the hospital was essentially what produced this improvement in healthcare outcomes.
Rebecca, did you have any follow-up?
No, thank you.
Okay, great. Brooke, it looks like you have your hand up.
Yeah, I just wanted to go back a little bit to the supply issue because, you know, it also has knock-on effects for supply to other countries, particularly to low and middle income countries. One of the first things that happened in the COVID response was countries imposing export controls on PPE, including the US, but there were at least 80 countries that, according to a WTO study, that imposed export controls within the first 2 months of the pandemic. And you know, the issue is still in the US policy. They have required, well, they haven't allowed US aid recipients to export US PPE without prior approval by HHS, which I think, I'm not sure it's ever been granted so far yet. I haven't checked in the last 6 weeks or so, but there was a big backlog for a while. And so, you know, that kind of relates to the other issue that many people have been working on, which is, you know, what's being called, vaccine diagnostic and therapeutic nationalism, where the rich countries are basically, even though supplies are, maybe especially because supplies are limited, there's a turn to nationalism as a, got to take care of me first before we let it go anywhere else. And so to me, this is an additional argument of why the supply question is so critical. And that, you know, if we don't, I mean, innovation is one thing, but supply is actually in many ways the bigger deal, because then it leads to hoarding and you know, price gouging and you know, low and middle income countries are always at the back line. And we're seeing it, you know, especially in diagnostics now, but it's certainly true in PPE as well.
Yeah, I think that's an excellent point. The reason I brought up innovation was because some of these reports were about a decade old, saying that at the time we really felt like innovation was necessary, and to date it really hasn't happened. Of course, in the urgent setting, the best approach forward is to mass produce what we do know how to make and make well. I think one of the biggest concerns is that the United States does import a significant percentage of medical devices from other countries, and that includes PPE. And so we were already in a situation where we were dependent on importation for a number of these products. And so, as you mentioned, the nationalistic sentiments that may be coming from other countries would mean that our supply chains for certain types of PPE could be cut off abruptly.
Any other questions or comments?
I'll ask something since it's quiet for a second. I'm just really curious where your group, what's the goal for this group after going through this crisis? You know, you've started something new. Are you going to become the new 3M? Is that the goal? But seriously, where do you see, is the goal just to push and innovate and write about it and pilot? Is it actually to create a new production capacity? Where do you see this project going?
Yeah, so because I was brought on as part of a larger group, you know, the goal or the group was really being driven by our supervisors and mentors. And so I think they see it as something that is winding down. We've contributed to NIH 3D print exchanges. We have pre-publications and publications looking at validated products. We are doing our best in terms of information dissemination and community conversations. We're currently working with partners in health to try to get them some mask frames and some of the other products we've innovated. We're trying to get them a cheaper and easier to assemble and ship face shield. So the device we developed with the lid on the top of the forehead and the wider piece actually takes about 4 hours to print, whereas there is a cheaper alternative that is essentially two pieces of this plastic that can be fitted and assembled and shipped flat. And so the idea there is, obviously, if we want to help supply other countries, that's the most optimal way of doing it, producing higher volumes and shipping more quantities at once for lower cost. And we're also in tune with some of the schools that are reopening. So we're having conversations with educators and community members about their needs for PPE. But I think it is somewhat of a fragmented approach. So we never wanted to develop a nonprofit manufacturing facility. We do partner with local manufacturers in terms of scale up of certain products, but it hasn't ever been something that we thought should be, you know, we're Harvard Medical School, we're doing research, we're trying to help out as much as we can for clinicians that are right across the street, but at the same time, we're not looking to compete with 3M.
Is there IP owned by Harvard? I mean, Harvard,
So
obviously, medical school sells a lot of license, a lot of IP, a lot of for-profit companies for a lot of money.
Well, we have MIT engineers, we have Harvard Med trained researchers on this team, and so we went to the tech transfer offices of both Harvard and MIT, and they said, you know, during COVID-19, anything that we develop within those walls that can benefit the COVID-19 response, they're keeping everything open. So they don't want to pursue IP on any of it. You know, and I pitched the idea of a design patent for the PAPR that was developed, because my thought was, you know, anybody could take the specs, tweak it just slightly, and then charge. You know, I think it cost maybe $600 to produce the entire device. So someone could turn around and charge $3,000 and manufacture and sell that same exact device. So that, I think that was more of our concern. It's not necessarily that we were looking to mass produce, but we were looking to partner with people who could mass produce at cost, rather than have a commercial entity come in and capitalize on our IP that we produced and developed.
Michael, in the little bit that we have left, I'd love, and maybe somebody else has a question as well. I'd love to hear more about the relationships and collaborations that you are working on with schools. I've been watching a lot of updates and reading a lot about what schools are doing and how they're having to restructure their classrooms, and how some of the guidance that a lot of schools are getting are very different, and in some ways less stringent than guidance that we're seeing elsewhere. So for example, you know, we're supposed to be 6 feet or at least 6 feet, depending on, you know, which version of the CDC guideline we're working with. But schools are actually being told that they can do within 3 or 6 feet. And so, for example, even as early as this morning, recently as this morning, I saw pictures of classrooms where they had some of those plexiglass and tube dividers at the same table. So students actually weren't, I don't even think that they were within 3 feet. I think they were less than 3 feet away. But anyway, so I guess it's one thing. Maybe a different question of like, why are schools less significantly kind of rigorous in some ways? And so are you hearing that those are some of the concerns that maybe teachers and administrators and staff are having? You know, there's also new guidance that talks about how bathrooms, we actually should be a lot more concerned about the spread of COVID in restrooms than we have previously been told, right? And so, you know, that's something that I saw recently with school administrators and maintenance staff, is that there's a lot of concern and they're not necessarily feeling like they have the appropriate equipment. And so I'm wondering, is that kind of why you've been collaborating with them, and just maybe some of the insights and observations in that area you could offer?
Sure. So our primary thought was how to supply, you know, some of the products we produced to healthcare workers, but to also have conversations that allay some of their concerns. But I will say some of the additional research I've been doing sort of on the side, even from the PanFab group, is looking at environmental, air conditioning, and other types of exposures in the office setting or in the school system. And so some of the air conditioning engineering experts that I've talked to, you know, they say really the best thing to do is to get a HEPA filter for each room, to open windows when possible. Obviously, this is going to be seasonal. We can't keep the windows open in New England winter. Other things that I found looking at bathrooms, for instance, air dryers are, you know, they can aerosolize all kinds of things, including viral particles. And so those are things that I think people aren't necessarily thinking about as much. And it's one of those situations where, you know, that prevalent understanding or that community understanding of the modes of transmission really affects how precautions are being taken, right? So there was a great article in the Atlantic talking about hygiene theater. And so essentially the idea there was that everyone thinks that fomites have such an important role in transmission of COVID-19. So wiping everything down with bleach, 5 times a day is the answer to that. Whereas this proximity is more likely to be the issue. I've seen some schools, I think there was at least one report that I read about that schools were essentially playing musical chairs with some of the children, such that as long as they weren't next to each other for, 15 or 20 minutes, they could stay underneath the guidelines and the limitations that the state imposes in terms of testing and quarantine. And so I think that's the bigger challenge is, to me, it's not how do we, to some extent, it's, do we absolutely need to get children back to school? I think there's a strong reason to do so, but I really think if you're doing so in a way that is not safe, I think that's the real problem. And the other I think fallacy that people are hedging on when they think about school safety is this idea that children do not transmit the illness or are not exposed as severely and have less severe illness. Now, I think that the understanding is starting to evolve that sure, maybe the children don't have as severe of an illness still, but they are able to spread it to adults when they go back home. And so I think that's a real danger.
Yeah, thank you for that. Yeah, I've seen some stuff where they talk about rotating the students or just switching them in a desk. And I'm just like, oh gosh, it's still within, for no matter what amount of time you've still been in proximity. So what's going on? Anyway, thank you for that. Do we have any final questions?
If not, I just really want to thank you, Michael, both for your contribution to the playbook, which is great, and really excited to have you on the team, so to speak, and for presenting to us and having this conversation tonight. There's a lot more we can say, and so maybe we'll pick it up again at some point, although everything might miraculously go away. So again, everybody, thank you for coming. We reconvene on the October 5th when Aziza Ahmed will be talking about issues of racial justice. And then a few other coming attractions on October 9th. Leo Beletsky and Jessica Bressler will be talking about carceral systems and COVID. October 26th, talking about elections, who knew? But particularly also around some of the challenges that COVID has presented for the election. November 2nd, Margot Lindauer and Morgan Wilson will talk about domestic violence. And then on November 9th, Brooke and Jonathan Kahn will be talking about vaccines and equitable access. Then that gets us through the fall, and we'll see what the winter brings. So thank you so much, Michael. Thank you, everybody, for coming. Take care.